This podcast provides general information, not a substitute for professional medical advice. Please consult your physician for personalized guidance.
Hello everyone, welcome back to Psych Rounds, and today will be our first episode with a guest on the podcast, and we have a pretty big one. We have Dr. Roger McIntyre, who is a professor of psychiatry and pharmacology at the University of Toronto, and head of the Mood Disorders Psychopharmacology Unit at the University Health Network. He's done a ton of research in psychiatry as a whole, and specifically has contributed to many guidelines, including the CANMET guidelines for bipolar disorders, and in 2014 was named one of the world's most influential scientific minds. He's a frequently sought out speaker. He's been on a lot of other amazing podcasts, and we are very, very grateful to have him today. Dr. McIntyre, is there anything else you want to add to introduce yourself?
No, just a robust thanks for having me, and what a privilege it is to be an advocate for people living with mental illness and their families. So thanks for having me.
So this episode is going to be more informal compared to some of our past episodes. It's going to be more discussion-based, really just being a conversation or a broad Q&A, and we'll kind of just see where the conversation flows.
Sounds good with me. I like that. Let's just iterate, and hopefully our GPS of our conversation will take us in a coherent direction.
So, Dr. McIntyre, we're going to kick it off here, as most of our listeners are familiar with the various bipolar disorders and the subsequent DSM criteria. However, the first question of the day is, how would you articulate the nature of this disorder to a patient or their family? Because this tends to be a very difficult conversation, especially with our current media landscape. So things like TikTok, YouTube, and other media outlets, they are all out there. And I can imagine these conversations can be fairly challenging.
It's such a great question to start, and I agree with how you asked that question and then embroidered the question with some of that color around the TikTok world that we're in. I don't think anyone is unaware that we have a surfeit of disinformation and misinformation and lack of information. And that's just a general statement about the world we're in with respect to access to media. A second statement is, as it relates to literacy around mental illness and its treatment, I would have hoped that the local library or the local medical school or the National Institutes of Mental Health would be the primary source that people go to. It turns out it's TikTok, it's Google, it's the internet, and Hollywood. So these are not just ubiquitous, aspects of our day-to-day lives, but they're the principal store, if you will, where people go shopping for information as relates to mental illness and treatment. And I think that it is of no surprise to me or anybody that we continue to have, as it relates to, for example, bipolar disorder, but one could say this would apply to any mental disorder, but we'll talk about bipolar disorder, that there is a lot of misunderstanding and misinformation. And I think this comes across in different ways. First is, a lot of people automatically arrive at the conclusion that somehow they cannot live a normal life because they have bipolar. Now, part of this could be influenced by their own witnessing of bipolar in a family member or something of that sort. The other part about this is, look, I think you have to be a champion to find any information on the internet as it relates to medications for bipolar that actually say good things about the medication. I mean, I'm sure there's probably better things being said about Satan than there is about psychiatric medications. So it's not like you can find much good information out there, and all you hear is disaster, 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 more Scientology, and then disaster, disaster, disaster. So not to be kind of light or funny about this, but I'm being serious. I've often wondered, why do people even want to even take their medications, read what they read? People who take treatments, who get their lives back, don't write blogs all day about how much life is awful. They get on with their lives. And the other part, just to wrap that up, is I think that for too often, what will happen is that people will feel somehow that there is really no hope for them and that there's really nothing that can be done for them. So I would say that for me as a psychiatrist, and why I purposely really emphasize that beyond my embroidery of credentials and bona fides, that I really see myself more of an advocate, not just with respect to political and, advocacy and things of that nature, my role as chairman of the board of DBSA, but really, in fact, trying to provide knowledge. I'm not certainly the paragon of knowledge, but I see myself as trying to provide accurate information. I probably spend most of my time in the area of literacy enhancement, literacy on disease and literacy on treatment. So it's a major, major problem. And I think it does not only manifest as stigma, lack of trust in the treatment and the care system, but unfortunately, a real nihilistic and defeatist kind of understanding as to what the prognosis is and can be. So I think this is, for me, a primary therapeutic consideration when I meet people with bipolar disorder.
Yeah, thanks. I really like the emphasis on advocacy, especially as like a counter voice to the vocal anti-psychiatry kind of movement that exists and present online, like what you were saying. I'll flow next into a very broad, open question, just to kind of see where we go. But a lot of our audience is medical learners, residents, young attending. So what are like the top 2 or 3 things you would like to say to help educate on bipolar disorder? That's kind of the focus where we're going with this discussion, mainly to kind of give them an idea of the diagnosis or treatment landscape or any other kind of clinical pearls that come to the top of your list.
I think what comes to my top of my list right away for all healthcare providers is that bipolar disorder, for most people with lived experience, is missed. It really is missed. And if it is detected, it's often not detected to many, many years, 5, 10, sometimes 15, sometimes 20 years later. And for me, that would be, I think, the most important modifiable deficiency. In other words, I don't think one needs to sign up for any health science degree to assume the longer a disease goes untreated or inappropriately treated, the more likely this is going to go in the wrong direction. And that's absolutely the case in bipolar disorder. So in other words, what I would say is that throughout my career, it's approaching now, getting closer to 30 years now, of having this privilege of meeting families and people who have lived experience of bipolar disorder and depression. I would say that the elephant in the room, the gorilla in the room, whatever the phrase we're going to say, is that we're not getting this diagnosis detected early and accurately. And there's ways we can do that with screening tools. They don't diagnose it. They help triage our considerations and time allocation. www.rapidmoodscreener.com is one of the screening tools that we really, really try to emphasize. And then the second part is that it's called the implementation gap. Now, the implementation gap is not unique to bipolar or psychiatry. It's right across medicine. Simply put, what does the knowledge tell us we should be doing and what's actually happening at the point of care? And we have tremendous mismatch. In other words, what most people are being treated with bipolar disorder and what the evidence tells us we should be doing is evidenced by approvals and clinical practice guidelines, algorithms, and expert opinion. It seems like it's 2 different worlds. So in other words, I often tell patients and families that we're going to take your treatment and we're going to change it to what the evidence tells us you should be on. And so much of the burden of illness, so much of the cost of illness, the recidivism, the healthcare utilization, and some of the dire outcomes, I think are preventable in the sense that people have a huge gap, a chasm between the evidence and what's actually happening. And then third and finally, what I would say is, and it relates to what we talked about a moment ago around literacy, bipolar is a chronic illness. In other words, it's an illness that it doesn't burn out. You have it for the rest of your life. And too often what happens is people stop their treatment or they start to fiddle with their medications and so on and so on. And all I would just say is that if I was to, and I've said this comment to a lot of my students, grad students, and just colleagues internally, that I think that the majority of what I have done as a psychiatrist in my career is make the diagnosis that's been abundantly obvious for 10 years. Secondly, get my patients to stop using all the stuff that doesn't really work or harm them and get them on the stuff that does work. And thirdly, just try to keep them on the treatment plan through support, education, advocacy, and what I've observed is many great outcomes. So I think, look, I don't want to put a sugar coating on it. Many people have unfortunately, a very bad outcome, but most can do quite well. And I just would say that, yes, we need a new cure. I'm so interested in curative therapies and disease-modifying therapies for bipolar disorder. But if we would just get this thing diagnosed, timely, accurate, let's try to have coherence and some kind of semblance of science to what people are actually taking. And then try to think about this not as a 3-week illness or a 6-week illness, but think long-term. I think we can make a hell of an improvement in people's outcomes.
Yeah, and I think I really like the discussion about diagnostic delay and kind of the diagnostic clarity and importance of that. And it flows pretty well into my next question. I was wondering, I hear sometimes debate or topics about inter-rater reliability and things like that. I was wondering if you can comment on your perspective or the data around the nosology of the bipolar disorders and where everything kind of fits into place with that.
Nosology and definitions, there's such an interesting history to that. And, bipolar disorder is a relatively new moniker. Way back in the day, of course, many would remember manic depression that came from Mel Kreplin, and then we had Vicordia from Kalbaum. But even back in the 1800s, we had concepts from the French emissaries like folie circulaire and folie double-forme. And so the names matter, and names often reflect the conceptual framework of the day. And with respect to bipolar disorder, we have now bipolar disorders. So we have bipolar 1, bipolar 2. We also have cyclothymic disorder in the so-called not elsewhere classified categories. I think for me, the way I think about bipolarity and its name is that over the years of sort of marinating ideas around this, I'm not so convinced this is a bipolar illness in the sense of high and low. That's a fairly reductive way to think about it. I really see it as being a fundamental lesion, so to speak, in the organization of mood, of cognition, of behavior, which maps onto disorganization or lack of synchrony, if you will, within the brain circuitry and networks, and one could cascade down right into the cellular molecular systems. So, this is a condition which I think now is recognized also as being one that, although it's defined by mania and defined by hypomania with respect to bipolar 1, bipolar 2 respectively, it principally is a depressive illness. In other words, that's the polarity that's most predominant longitudinally in the first presentation, and certainly when people come to clinics. So I think that the way we think about bipolarity is it's multidimensional rather than two different poles. And it's one wherein the burden of the illness disproportionately is accounted for by what really turns out to be difficult to treat or more persisting depressive symptoms, often admixed with cycling and anxiety. So I think that what I'm describing is not only accurate in reality in the real world, but I do think there's a lot of folks across other areas of medicine, because their rotation in psychiatry is relatively brief. They may not have a lot of exposure. Maybe that exposure was on inpatient units only, things of that nature. And part of this is propagated, I think, by Hollywood in the sense that bipolar is, conceptualized as elated, grandiose, euphoric mania with mood congruent psychosis. And of course, that's factually true, but that's a fairly narrow phenotype of bipolarity, and the predominant phenotype is one of sort of a mixed, dysphoric, anxious, depressed presentation, which makes it challenging, I think, for a very brief office visit to not only contemplate, think about what are the high-yield questions around bipolar in that brief encounter, and then to arrive at an accurate diagnosis.
And you just mentioned cyclothymia. So I just have a quick question about cyclothymia as well as something like major depressive disorder with mixed features. So I find both of these kind of difficult to diagnose, at least at my level currently. How similar would you say these two disorders are compared to bipolar 1 and bipolar 2 in terms of the underlying pathophysiology? And I was wondering if you could give us some tips on how to diagnose them.
Absolutely. I would say that for myself, many, many years, over 100,000 patient encounters in my career, I still struggle with the diagnostic differentiation that you just articulated. Insofar as I think mania, and coming back to this point about inter-observer agreement or reliability, I don't think anyone's going to be surprised that bipolar 1 disorder, defined by mania, has greater inter-observer agreement than bipolar 2, which by definition does not have mania. And then when you look at cyclothymic disorder or MDD mix, you're really getting even more into the concerning low levels of inter-observer agreement. Now, to be fair, the DSM-5 text revision and its authors, circa 2022, the updated version, have codified these diagnoses, and of course, there's criteria, there's field trials that have instantiated the reliability. But reliability comes in different shapes and sizes, low, medium, and high. and unfortunately, they're quite low for some of these conditions, which means for you and I as clinicians in the front line, we're like, okay, where does this patient reside? Now, someone might say, well, who cares? What does it matter? Life is short. Why are we anguishing? Well, it does matter with respect to psychoed, prognosticating, patient care planning, treatment selection. It does big time matter. And as it relates to bipolar 2 and cyclothymic disorder, the evidentiary base as it relates to the therapeutics of cyclothymic disorder are slim to none, to be quite frank. We just haven't really studied therapeutics for this condition. Cyclothymic disorder is a condition that, by its very nature, is subsyndromal. These are people who have subsyndromal mania and subsyndromal depression. And then one might say, well, hang on, isn't that everybody in society? Who doesn't have like occasional days of being down or, low energy, maybe amotivated, maybe some days more chirpy, more excited, maybe, more sort of active? Where the heck is the line between that and people who are experiencing cyclothymic disorder versus healthy controls? Again, we go back to the DSM, and the DSM has had as a guiding principle the guiding principle being, is it distressing and or impairing? And I have to say that in my career, less than 5% of people referred to me have been diagnosed on exit with cyclothymic disorder. Major depressive disorder with mixed features. Got an interesting story. This is, of course, came in DSM-5 circa 2013. Very neo-Krepelinian. In other words, going to more of a dimensional characterization of mixed symptoms rather than a categorical. In other words, in the old days, before 2013, you couldn't diagnose mixed in an MDD patient. It was only in a bipolar patient. But the DSM authors were very wise in acknowledging that hypomanic symptoms are not diagnostic of bipolarity. Again, let me repeat that. Hypomanic symptoms are not diagnostic of bipolarity. They are probabilistic. They're suggestive. Anxiety symptoms don't diagnose GAD, generalized anxiety, or panic, or social phobia. It's a cardinal feature, but it doesn't diagnose it. If you have hypomania or you have mania, that's bipolar 2, bipolar 1, but hypomanic symptoms do not diagnose bipolarity. And about 25 to 30% of people with MDD have mixed features. It's very confusing. It's like saying you got MDD and bipolar at the same time. No, we're not. What we're saying is you have some hypomanic symptoms. Now, if out of 100 people with MDD with mixed features, maybe 20, 25 will eventually declare themselves as bipolar. But the majority will retain the diagnosis of MDD. So it's part of the condition. I think to arrive at the diagnosis, whether it's MDD mixed and or cyclothymic disorder, you go back to a very famous paper. Now, in medicine, there's hundreds of papers published a day on PubMed and all these search engines. But every 10 years or 20 years, there's just this seminal paper comes out. And in 1970, Robbins and Guzay published a paper, What Validates a Mental Disorder? It was just brilliant. It was so simple, yet it was just so futuristic. And so what you're looking at is the phenomenology, the age and onset, the longitudinal course of the illness, looking at family history, looking at response to treatment. And every time I find myself getting lost, which is a lot of the time, or anytime I find myself diagnostically in like nowhere land, which is a good portion of the time, I go back to Robbins and Guzay's validating factors. And these are, what is the phenomenologic characteristics? What's the age and onset, longitudinal course, family history, response to treatment? And I won't say that always takes me to the diagnostic promised land, but it certainly, in fact, gets me a little bit more back on track. Let me just say a bit more about that, because this has turned out to be so true. I call it the 75-25 rule, that 75% of people living with a bipolar illness have age at onset before the age of 25. My little observation is what I call the 4 A's. Now, everyone knows the Bloilerian 4 A's. Bloiler coined the phrase schizophrenia in 1908. He also introduced the 4 A's of schizophrenia, known as autism, ambivalence, association, and affect. Well, I thought we needed the 4 A's of bipolar disorder. In other words, most people with bipolar, when they are ill, when they come to a clinician especially, they have one or more of the 4 A's. What are they? Anxiety, agitation, anger, and attentional problems. To be clear, that doesn't diagnose bipolar. Those are probabilistic factors. Anxiety, agitation, anger, and attentional problems very often index mixed features, which is more common in bipolar disorder. So I'm always listening for the 4 A's, taking my Robbins and Guzay validating factors. Not every time, but most times it gives me a working diagnosis that I'm comfortable with. And that then guides my treatment. And for me, those remain today the guiding principles. One final little point I want to add on is pattern of comorbidity. Sometimes we can learn a lot about what the diagnosis is by what the comorbidities are. In other words, we know that people who live with bipolar disorder have much more comorbidity than people with MDD, major depressive disorder. In fact, on the exam question is, which mental disorder has the most comorbidity? The answer is bipolar disorder. And so if I have a patient who's depressed, I may be getting some of those mixed features, and I'm still not quite clear after I did my Robbins and Guzay, around the horn. But the patient says, I've got a past history of ADHD when I was a kid, and as an adolescent, I had panic disorder, and I abused alcohol in my early 20s. And now I've got migraine headache, and I'm also overweight, and I binge eat. These really get me suspicious, because everything I just articulated is much more common in bipolar, especially migraine. In fact, about 10 to 20% of people with bipolar 1, 20 to 40% of bipolar 2. So sometimes when you're the lawyer in the courtroom, you're trying to build the case beyond a reasonable doubt. And so it's all these pieces of circumstantial evidence I like to gather, so to speak, in the courtroom to build the case beyond a reasonable doubt this person has bipolar 1, 2, cyclothymic, or MDD mixed.
Wow. Well, that was probably one of the best explanations I've ever heard of both disorders. As a quick follow-up question with regards to treatment, you did mention that for cyclothymia, there aren't really any great therapeutics. But if you had to choose for both cyclothymia and MDD with mixed features, I was wondering what therapeutics to use. So for me personally, for cyclothymia, I've generally used something like lamotrigine, and for MDD with mixed features, I find that the evidence is probably most compelling for something like lurasidone.
Yeah, I really going to land in your camp on that. I completely agree with you. I think that in a cyclothymic disorder, patient. A patient, that's the diagnosis you're putting into the chart. For me, pharmacologically, again, we have an evidence base that's almost, it's kind of evanescent. There's almost nothing even there. But I think it would be coherent and very reasonable to consider lamotrigine. I also think, and I've had some success over the years with lithium at a very low plasma level, 0.5, 0.6 in some patients. That sometimes helps my patients. Very often, and not to mucky the waters, but the waters are mucky, but a patient with cyclothymic disorder, often this is a consequence of the cyclothymic disorder. They often have very maladaptive interpersonal histories, and they often have the Venn diagram with a concurrent personality disorder. And I can tell you it's often difficult to parse that line between borderline pathology or narcissistic pathology and cyclothymic disorder. Where I'm going with this is I have had some success with low doses of atypical antipsychotics in affecting people who have chaotic aspects to their mood disorder, which often overlaps with cyclothymic disorder. Admittedly, atypicals, I would probably see more third line in cyclothymic disorder after lamotrigine or lithium. In people who have MDD mixed, you called out lurasidone. I completely agree. I might add to that drop-down menu insofar as we've had good success with lurasidone, lumateperone, as well as cariprazine. And a little bit of disclosure here, I've actually been involved in evaluating each one of those three across the mixed features spectrum. In fact, there just was a recent study I was part of where we took adults with either bipolar 1, bipolar 2, or MDD with mixed features, and we gave them lumateperone or placebo, and lumateperone was considerably more effective than placebo, and it was safe and well tolerated. So I think the two L's, lumateperone and Latuda, and the C of cariprazine, that's where I'm landing more and more on MDD mixed. Some might be saying, hang on now, what are these guys saying? I thought MDD is treated with an SSRI or SNRI or vortioxetine. I'm hearing that loud and clear. People are going to be thinking that. And what I would say is as follows, is that MDD mix has not been adequately studied with SSRIs, SNRIs. Often it's not clear, is this mixed features or is this anxious features or both? And certainly SSRIs, SNRIs, vortioxetine, vilazodone, treatments like that can be very helpful in MDD with anxiety. It's anecdotally the case, rather than sort of real world evidence, RWE, rather than RCT, randomized controlled trials, that when a person with MDD and mixed features presents and they receive an antidepressant, they just don't do as well. And we do better with these atypicals. That's why we tend to gravitate more to those. Some clinicians start with an SSRI or SNRI, see what happens. And if things don't improve and they consider the atypical add-on, in other circumstances, what they might do is they might just go with an atypical first.
Yeah, I wanted to follow up with that as well. A very quick question. I'm curious, I feel like anecdotally, I've seen sometimes patients almost get, I don't want to use the term like downgraded, but almost somebody who's treated with bipolar disorder almost begins to appear more cyclothymic in time. Is this something that you've seen at all or that the data supports, and is it an indicator of successful treatment or suboptimal treatment?
I think what's clear is that someone begins with cyclothymic disorder, and then over time they may transition into bipolar 2 or bipolar 1. I think that is absolutely the case based on some longitudinal work. To be really clear, once you have a diagnosis of bipolar 2 or bipolar 1, you can't then sort of go down to cyclothymic disorder, so to speak, in the sense that you can't have your diagnosis be relegated downward, but it can be relegated upward, so to speak. But I think what you're getting at is something really interesting, and that is, it is true that many people with bipolar 1 or bipolar 2, when they take treatment, they come back to the clinic. and you're doing mood diaries, you're checking symptoms, you're talking to family or loved ones, whoever they bring to the appointment. And what's everyone's agreeing on in the office is that things are better. So we're all agreeing things are better. What we're also agreeing is they're better, but there still is this sort of mood dysregulation. And the mood dysregulation is not of the excursion of mania or hypomania or depression, but their mood is moody. I call it dysrhythmic mood instability. It's just there's something not quite right. And they're often very reactive. There's a reactivity to it. And what's interesting is that when one does evaluations, neurobiological studies, like for example with MRI, and you expose a person in the MRI scanner who has bipolar disorder to a stimuli, there is a reactivity that they have. There's a hyperreactivity, which appears to be trait. It appears to be part of the illness. And in many cases was probably a phenomenological antecedent to hypomania or mania. But it certainly is a residual. That's why during the so-called asymptomatic period, that is between episodes, people are often not asymptomatic. They continue to have cognitive problems, sleep problems, comorbidity, continue to have this affective instability that looks like cyclothymic disorder. But it's not cyclothymic disorder proper. It represents the trait of bipolarity characterized by affective reactivity, instability, kind of an emotional and cognitive dysregulation. For some patients, what they find is psychotherapy can sometimes help that, CBT or mindfulness. Other non-pharmacologic approaches could be around exercise. 1 in 2, 50% of people, 1 in 2 people with bipolar disorder who are perfectly asymptomatic meet the criteria for an insomnia disorder in the DSM. And when you have a abnormality in sleep-wake behavior, that is a index of a circadian disturbance or a disturbance in the chronobiology. And so I think for many of my patients, that affective instability is to some extent treatable by doing a better job at treating the sleep problems. And then finally, comorbidity. Let's face it, it's the rule, not the exception. And I think alcohol, cannabis, of course, illegal drugs, but also obesity, overweight, diabetes, metabolic syndrome, these are mood destabilizers. So by targeting these other aspects of the presentation, one, of course, is doing something which is good, but you're also getting this halo effect with respect to better mood stability in some cases.
Dr. McIntyre, there's one point you briefly touched on there too as well, and I've heard you lecture this multiple times on some other podcasts as well, but this idea through training that we go through, I think it's more common in medical school, but this perception that bipolar 2 is in a way a diet bipolar 1 disorder.
You know, it's interesting. When I started in the field, bipolar 2 was certainly considered a milder phenotype of bipolarity. There's no question. I think that was a carryover of its definition, maybe an externality, an unintended consequence, in the sense that clearly hypomania, by definition, is less severe in its presentation than mania, by definition. So therefore, bipolar 2 must be less severe. Bipolar 2 is a relatively newer construct. It was first articulated by David Dunner's team in 1976. And throughout the time I've been in the field, it was always this sort of basic assumption that it was milder. Over the years, that has considerably changed. And I think it's changed because there's greater recognition of the phenomenological spectrum of bipolarity. Secondly, there's been a lot of sophisticated analysis that have sought to determine what are the aspects of bipolar disorder that are really mediating most of the burden of illness, the drop in health-related quality of life, the functional outcomes, the problems with work attendance and productivity, shortened lifespan, shortened health span, and general economics. And it turns out it's depression and cognitive impairment. And when you look at bipolar 1, bipolar 2 together, you juxtapose these two entities together, bipolar 2 disorder, not only at the population level, is more common than bipolar 1, but also when you look at the symptom structure, bipolar 2 is even more so a depressive presentation, more episodes, longer duration, more difficult to treat. And evidence now has emerged, replicated, that the suicide completion rate in BP2 is not lower than bipolar 1. In fact, some people might think it's higher. So I think we have to approach BP2 with the empirically supported belief system that it is as debilitating, as burdensome, frankly, as lethal as bipolar 1. And that, for me, is a convulsive change in the field, because the field had really so much emphasized mania as the debilitating aspect of bipolar. Of course, it's debilitating, but it's relatively brief. Mania is a relatively brief excursion. Depression goes on for months, in many cases, years. So, a very superficial comment that I sometimes make is, what's more debilitating, being severely manic for 3 to 5 weeks or being depressed for 3.5 to 4 years? I think it's obvious which one's worse. And so I think this has really provided the impetus for people to really rethink BP2. Unfortunately, we have very few therapeutics studied in BP2. Only quetiapine and lumateperone have FDA approvals in BP2. And so just like cyclothymic disorder, all of the attention's been given to bipolar 1. It's almost like it's the preferred child. And then bipolar 2 and cyclothymic, the neglected child, so to speak, in a sense, we haven't studied them as much. And so we extrapolate our treatment data from BP1 largely to BP2. But we got some nice data now for lumateperone, mono and adjunct, and we had some older data for quetiapine, which was also very effective in BP2.
Dr. McIntyre, thank you for that very insightful conversation. We are going to go ahead and take a break for both our audience and for Dr. McIntyre. We will be splitting this series into 2 separate episodes, the first of which you are listening to right now. The second episode will go ahead and air this coming Friday. We want to thank again Dr. McIntyre for coming on as a guest. He is a leading expert in the field of mood disorders, so we're very grateful to have him on. And to our listeners, thank you for listening to Psych Rounds. Have a great rest of the weekend, and we will see you next time.